Hi, everyone. Welcome to our next week of boot camp for Tickborne Boot Camp. I'm Dr. Kim Bruno, your host, and we've had some great weeks so far, and I'm really excited to introduce you to Dr. Summer, and she's going to talk to us today about autoimmune encephalopathy, autoimmune and immune dysfunction, and really how it is relating to Lyme. So Dr. Summer DelSignore brings a unique vision to pediatric health, aiming to change the lives of children and their families dealing with complex health conditions. With over 20 years experience, she's dedicated to identifying the underlying causes of immune dysfunction and tick-borne diseases such as Lyme disease, PANS, autoimmune disorders. Noticing the limitations of traditional healthcare's focus on symptom management, Dr. Summer was inspired to integrate the depth of integrative care to the precision of medical science. Her educational training in pediatrics from Penn and her doctorate from SUNY's Upstate Medical University, combined with mentorships from experts like Dr. Richard Horowitz and Dr. Kenneth Bach, has equipped her with a global reputation for developing proven treatment plans. At Hudson Valley Integrative Health, Dr. Summer has introduced a revolutionary 10 key approach to address the root causes of immune dysfunction. As pediatric board certified provider, a member of ILADS, and a fellow at the American Academy of Ozone Therapy, she ensures her treatments are guided by the latest research, blended with her expertise in genuine compassion to offer hope and improved quality of lives to families. Beyond her technical skills, Dr. Summer prioritizes nutrition, lifestyle, and mental health, highlighting her commitment to treating the whole patient. The Summer Institute, her brainchild, stands as a testament to her philosophy, combining rigorous, data-driven approaches with a nuanced understanding of health. It's the dedication and personalized, informed care that distinguishes Dr. Summer's practice, making it a beacon for those who seek alternatives to conventional medicine and fostering a healthier, empowered community. So thank you so much, Dr. Summer, for joining us today. I am so excited for your presentation, and I'll let you take it away.
Great. Thank you, Dr. Bruno. Thanks for the introduction. So the past couple of weeks, we've heard in-depth explanation of vibrant testing by Dr. Bruno and a comprehensive overview of pathophysiology and Lyme disease, co-infections, and a naturopathic approach by the brilliant Dr. Hinchy. So today we're going to focus in more upon a poorly understood condition that plagues many individuals dealing with Lyme and tick-borne illnesses. I primarily treat pediatric patients, and I see a varying degree of neurocognitive dysfunction with all of them. So today's focus is tick-borne autoimmune encephalopathy and immune dysfunction. It's not just Lyme. So we'll go through utilizing the 10 root cause categories of immune dysfunction to formulate a comprehensive diagnosis. And hopefully I can share with you how some of the stacking events can occur that will contribute to varying degrees of encephalopathy. So here are my disclosures. So the objectives today will be to discuss tick-borne illness connection to autoimmune encephalopathy in children, provide an overview of autoimmune encephalopathy, explore unique symptom presentations within the pediatric population, which will be conveyed to the adolescent case study presentation, and then briefly review and examine the 10 root causes of immune dysfunction approach to diagnosis. So what I'm going to start with is explaining what autoimmune encephalopathy is. And what you'll see peppered throughout this presentation are QR codes that will provide you with additional research articles or information that you can read at your leisure. So encephalopathy refers to inflammation of the brain. So autoimmune encephalopathy or encephalitis occurs when the inflammation is triggered by an autoimmune response. So your immune system mistakenly attacks your own brain cells. Lyme disease is a multi-system infection and can cause central and peripheral nervous system dysfunction. It can be challenging to differentiate between neurological disease and other disorders affecting behavior. So understanding all behaviors require a properly functioning nervous system. The nervous system function can be affected indirectly by systemic illness in the absence of any direct nervous system damage. Psychiatric diseases, which are thought to be fundamentally neurobiological, and presumably attributable to problems with neurotransmission, network dysfunction, and in some cases, a learned behavior, is biologically distinct from what is typically considered a neurological disease. Because neither systemic nor psychiatric disease involves structural damage to the nervous system per se, these disorders have quite different implications. So AE contributes to a myriad of subacute cognitive dysfunction, sluggish memory recall, neuropsych symptoms, and movement disorders. So it can be difficult to diagnose given the overlap with other infectious diseases like Lyme disease and tick-borne diseases. So the QR code referenced here is an NIH study about autoimmune antibody markers for basal ganglia, encephalitis, and chorea, and pediatric autoimmune neuropsych conditions. So the causes of autoimmune encephalopathy, we don't always know what triggers the immune system to misfire, but these throughout the research, infection, genetic predisposition, mold, and other environmental toxins seem to be major contributors. The infections may be acute or in low levels, slowly triggering an immune response. Environmental toxins like mold produce mycotoxins, which is a metabolite that can be neurotoxic in nature. And then all genetic and environmental exposures should be considered in addition to infection. So there are subtypes of autoimmune encephalopathy, and I've listed several here. When your immune system begins to erroneously target certain proteins or receptors in the brain, the type of protein or receptor targeted determines the type of autoimmune encephalopathy with the associated symptoms. There are several common structures that appear to be vulnerable to antibody production, and those are the ones listed here. And there are several subtypes of autoimmune encephalopathy that are very common with these antibodies. For the sake of this talk, we're going to focus upon anti-NMDA receptors, which appear to be most affected by Lyme disease and tick-borne co-infections that we find in the literature. So how can Lyme trigger autoimmune encephalopathy? So infections like Lyme disease, caused by the Borrelia burgdorferi spirochete, can invade the body, and initially the immune system can control the pathogen to a degree. If the Lyme spirochete colonizes and migrates to other tissues through epithelial cells, it can cross the blood-brain barrier. Your immune system eventually will recognize these foreign substances and activates an inflammatory response. So we have infection and toxin overload, and then followed by inflammation and immune activation. Once the blood-brain barrier is crossed, the Lyme spirochetes are in an immune privileged space, meaning that they're protected from the host's immune system and standard antibiotic treatment. The Lyme spirochete can persist, and your immune system cannot eliminate its target. This will trigger the immune system to continuously mount a defense, creating more inflammation. Your system cannot sustain this pattern long term and then begins to destabilize. Over time, your immune system will become depleted, causing suppression and later dysregulation, eventually creating autoimmune antibodies, meaning attacking its own cells. The Journal of Molecular Science published a postmortem study, and you'll see that in the QR code here, of Borrelia species found in the brain. So it was showing spirochete's ability to cross the blood-brain barrier. So now we're going to focus upon anti-NMDA autoimmune encephalopathy. So you kind of have a general overview of what AE is, how Lyme can cross over the blood-brain barrier and trigger AE, and now we're going to speak about the specific receptor that can be involved. So this is N-methyl D-aspartame receptor. That is anti-NMDA autoimmune encephalopathy. It's one of the most common forms. It's an extracellular inotropic receptor, which controls ion channel activity and protein and receptor interaction. So essentially it's a conductor telling things what to do. The literature suggests a stronger correlation with Lyme compared with any other type of AE. is crucial for neuroplasticity, synaptic transmission, human behavior, and learning. The pathophysiology of anti-NMDA encephalitis is thought to involve antibodies against the NR1 subunit of N-methyl D aspartate receptor. So essentially, ion channels are not properly exchanging and communicating. If NMDA is overactive, the nervous system gets excited. It's like giving a kid sugar. It can lead to things like epilepsy, dementia, and stroke. Decreased NMDA, which can also occur in autoimmune encephalopathy, can cause other symptoms similar to those observed in schizophrenia and autism. Psychiatric manifestations are common and contribute to symptoms of fear, panic, anxiety, compulsive behavior, sometimes inappropriate sexual behaviors, aggression, and rage. Physical symptoms of chorea, which is a rhythmic involuntary movement, can occur, dystonia, and in severe cases, a comatose-like state. Autonomic dysfunction is common in the acute phase of anti-NMDA, so people who suffer from POTS dysautonomia, if you've heard that term kind of floating around. And this is where you have manifestations of tachycardia, bradycardia, so a high heart rate, a low heart rate, and blood pressure instability can occur. So what we have here is a failure to communicate. Those of you who've ever watched Cold Hand Luke. Amino acids and proteins that make up neurotransmitters are typically plentiful and normally functioning prior to afflictions with autoimmune encephalopathy. Inflammation is the disruptor and contributes to improper communication pathways that lead to neurocognitive, behavioral, and physical symptoms. So I have a schematic here just to give a general overview of how this happens. This is a picture of ovarian teratomas, but the pathway is very similar for viruses and other bacteria. So essentially what happens is NMDARs are released by tumors and viral infections or other infections, and these neurons are taken up by what's called antigen-presenting cells, or APCs, after cell death occurs. So APCs then migrate to local lymph nodes, and with the cooperation of your immune cells, so your CD4, T cells, naive B cells, and lymph nodes, they become memory B cells and differentiate into plasma cells. These cells and anti-NMDA antibodies produce peripheral plasma cell and enter the brain. So if you look at the picture on the right, it says B next to it, that's where this exchange is occurring. So anti-NMDA antibodies are binding to something called GLUN1 subunits of synaptic and extrasynaptic NMDARs. So this disruption interacts with NMDAR, results in decreased NMDAR and neural hypoactivity, but antibodies can sometimes also increase these receptor openings, and that's what contributes to seizures and other hyperstates. Cerebral spinal fluid, CSF examination usually shows pleocytosis and oligoclonal bands, so increased protein and increased IgG or immunoglobulin G. EEGs, if you're looking at those as a practitioner, it will show diffuse slowing epileptic activity, which is considered characteristic of anti-NMDA encephalopathy. MRI scans are normal in about half of patients we see. And you could possibly see some signal flaring, some hyperintensities can be seen in the hippocampal, cerebral, and cerebral cortex area, and sometimes basal ganglia and brainstem. So doing a literature review of anti-NMDA encephalitis in patients, specifically with Lyme, all cases within the literature reported positive blood results and CSF for Borrelia burgdorferi antibodies, both IgM and IgG. Symptoms associated throughout the research showed memory loss, mood disorders like depression and anxiety to varying degrees, hallucinations and aggression. CSF did not always show inflammation. Fevers were not common given the autoimmune trigger versus an acute illness. Now, many providers can confuse acute viral encephalitis with an autoimmune encephalitis and disregard it if a clinical finding of fever or CSF inflammation is not present, and that's just not the case. MRI findings were unremarkable throughout this literature, and EEGs did not show seizure activity. So Lyme encephalopathy is referring to a toxic metabolic encephalopathy and reflects altered CNS function, but not CNS infection. So it's probably mediated by peripherally produced neuroimmunomodulators that cross the blood-brain barrier. So symptoms associated with autoimmune encephalopathy. And these symptoms can wax and wane, and can certainly vary in intensity and frequency. So you have things like anxiety and panic, OCD compulsions, flu-like symptoms, chorea, which is the involuntary movement of limbs or facial expressions, impaired cognition, processing, and memory, impaired speech, vision or hearing, stiff man syndrome, numbness, weakness, insomnia. So it can kind of run the gamut depending upon the structures affected in the brain. So what I want to do now is kind of tie all of this together so you have some background scientifically, which we could really talk for days about this stuff, and then explain this and view this in a real life situation. So this was one of the worst presentations in severity of symptom and the timeliness of onset that I've seen. So this was a 14-year-old female. She presented bedbound, nonverbal, non-responsive. She had minimal motor function. She was hypertonic and had a G-tube for feeding and urinary catheter for elimination. Her history revealed that at 11 years old, she had received an MMR vaccine with subsequent headaches that persisted for over a year. Noted prior to the MMR vaccine, the patient had had at least 2 known tick bites and was treated twice with short-term antibiotics. She seemed to be fine and stable at the time, persisted with the headaches, and then in 2020, she contracted COVID with rapidly progressive loss of fine and gross motor skills and severe cognitive decline. Through many evaluations with providers, she was diagnosed with autoimmune encephalopathy by her primary care provider and a neurologist. She was started on oral cephalosporins and low-dose IVIG. Her symptoms improved with treatment to baseline, but every 3 weeks would regress after the IG would wear off. So after 4 months of IVIG, her provider discontinued treatment and the patient regressed and worsened to a bedbound state. So what we're going to do now is go through the 10 root causes of immune dysfunction framework. And what you'll see on your screen are the 10 causes. And to your right is a Dr. Horowitz's MSEDS questionnaire, which essentially is looking at multi-system symptoms. It's a subjective form, but we utilize that to determine severity of symptom in patient. So James Clear said to us that we don't rise to the level of our goals, we fall to the level of our systems. And the root cause immune dysfunction framework provides a systematic approach to evaluation. So chronic patients present with many multi-system dysfunctions, and this approach ensures that you're addressing all categories with every evaluation in a systematic manner. We utilized Horowitz's MSED questionnaire as a springboard. We digitized it and then added additional questions specific for neurocognitive function to suit the needs of the patient population that we're most often seeing. From here, we created the immune dysfunction calculator that helps us prioritize system focus and monitor clinical correlation of organ systems affected. So using this, and this is the immune dysfunction impact assessment. So this is what populates. And at the top, you'll see that there is essentially intensity and frequency of symptoms. And then to the right is the MSEDS score, which doesn't determine severity of symptoms, but how many systems can be involved. Underneath that gives you an immune category reading and a body system reading, red meaning the most effective, and then it titrates down from there to green, meaning potentially no issue going on. So with this patient, what we identified in the immune categories were infection, emotional well-being, and cognition, which includes the neurological component, and gastrointestinal health. Systems involved from neurological, gastrointestinal, and cognitive. So utilizing the first category, evaluating the infection component, we reviewed medical records and identified several items here. One, the patient had IGNX labs that showed an equivocal IgM band 23 Borrelia burgdorferi, which is one of the main culprits of Lyme, as well as an IgG equivocal Babesia microti. She also had elevated ASO and DNASP antibodies for strep, elevated GAD65 antibodies, which would indicate some autoimmune encephalopathy, a reactivated EBV, so Epstein-Barr virus that contributes to mono, a positive tilt table test for POTS, so she had some autonomic dysfunction, an abnormal PET scan, and that's how it was reported to us. We didn't have reports to or scans to review personally. An elevated CSF protein, positive genetic markers for HLA-DRB, and positive MTHFR heterozygous C677T. So she had one MTHFR mutation. So what we did was order additional lab work through Vibrant Wellness. We did the Tickborne 2.0. Now, this was a messy case, and I found it important to present what we typically see in real life practice. Patients do not always present with complete diagnostics or history and may have many gaps in care. Another hurdle that we had to overcome is that English was the second language for this family, so there was a communication breakdown as well. As a clinician, you are playing detective. You have to make those connections and close the gaps to devise a comprehensive clinical diagnosis. So the diagnosis for this patient based upon history and presenting information was infectious triggered autoimmune encephalopathy, Guillain-Barré syndrome, stiff person syndrome secondary to Lyme, Babesia strep, and reactivated EBV. So acute therapy was initiated given her state. And essentially what we did was have a PICC line placed, which is an indwelling catheter that we can leave in for up to about 6 weeks and administer medications. So we started IVIG at 70 grams, 2 grams per kilo biweekly, and that's through the Toronto protocol, which you can pull up. I have it in the reference section at the end of this presentation. It's a very aggressive approach to IVIG therapy. She also started plasmapheresis every other week. She was given Mepron, which is an anti-malarial medication via her G-tube, as well as methylene blue. We started IV doxycycline twice a day, IV azithromycin and rifampin. She was also started on herbal drops via her G-tube from Research Nutritionals, which was a combination of well-researched herbals that are known to target viruses, multiple forms of tick-borne illnesses, and have some biofilm coverage to them. Additionally, we added stevia, biocidin, and probiotics to the mix while we were waiting test results to come back. So here were our initial test results. And essentially what we found were IgM, IgG equivocal Borrelia bands. We found more than just that IgM 23, so there were multiple, and then multiple strains of Borrelia. We found an EBV antigen positive IgG, Toxoplasma gondii, which is IgM positive, and Streptococcal A. So we gathered additional information. Now, I like the dry blood spot test. It's a finger stick for a couple of reasons. One, it's easy, especially for kids. It's easier to get a finger stick than draw multiple vials of blood. And the second is that it's a capillary blood, and capillary blood is rich in oxygens, and certain microbials, especially parasites, like that oxygen-rich state. So you can capture many bugs that way. The second root cause of her immune dysfunction was the emotional well-being and cognition. Now, this was difficult to ascertain once evaluating this child in person, because at the time she was not verbal, and it was really difficult to ascertain symptoms. So reviewing general labs with her seemed normal. And so we ordered a NeuroZoomer just to see where we were with those autoantibodies. But the parents did report prior to the nonverbal state that she did have elevated levels of anxiety and depression. She was having some cognitive struggles, some word recall issues going on. So the Vibrant NeuroZoomer initial results showed us that she had high levels of infection related primarily to EBV. And then she had moderate levels of anti-acetylcholine receptors, anti-neurophysin, anti-amyloid beta, anti-dopamine receptor 2, and then EBV was also in moderate. So these are different components of the neurological system, and these essentially are autoantibodies that we're seeing in this blood work. So essentially, the anti-acetylcholine receptor is an autonomic surface, can cause autonomic nervous system dysfunction. Things like POTS, conversion disorder, and impaired consciousness. Anti-nervation can be associated with Guillain-Barré syndrome. Usually, you'll find unusual spinal cord findings on an MRI. And you can have some polyneuropathy and white matter disease of the central nervous system. Anti-amyloid beta can contribute to severe cognitive dysfunction. It's most often found in Alzheimer's disorder. Anti-dopamine 2 can contribute to mutism, movement disorders, and psychiatric symptoms. And then the EBV antibody disrupts the blood-brain barrier. It can contribute to the neurocognitive dysfunction and neurological disease in absence of an active EBV infection. So her symptoms correlated with what we were finding here in the NeuroZoomer. So her IVIG and plasmapheresis were further justified and were continued, as were the other acute treatments that were initiated. So the third cause of immune dysfunction was her gut health. So her parents had reported fluctuations with diarrhea and constipation, bloating with cheap tube feedings, and a thick coating to her tongue. The patient was, again, nonverbal, and it was difficulty to ascertain these symptoms. We needed to tease out a true gut biome issue versus a nerve innervation issue triggering these symptoms. So there is a significant blood or gut-brain connection where gut bacteria imbalance can create this pro-inflammatory state in intestinal profile. And this can lead to accumulation of autoreactive T cells in the intestines and associated lymphatics. So the building of inflammation can loosen epithelial tissue junctions of the inner wall lining of the GI tract, and autoantibodies can then slip through these gaps and enter the bloodstream and make their way across the blood-brain barrier, especially if you have evidence of EBV virus punching holes in that blood-brain barrier. So just to kind of give you a little pathophys background. So we did order the GutZoomer just to kind of get a good sense of what was going on with her there and tease that out. So here are those results. And essentially the GutZoomer is going to go over general inflammation that you can find, any balances or imbalances of bacterial flora in the gut, and then if there are any things that are pathogenic in nature. So in this case, the gut didn't look awful from the inflammatory perspective. You had moderate levels of markers that contribute to IBS and SIBO, or small intestinal bacterial overgrowth. Nutrition levels with absorption was borderline, but again, like I said, it didn't match the clinical picture. We did find, though, Shigella-like toxin-producing E. coli, and interestingly, Shigella-like toxins are found throughout the literature as an endotoxin that raises ammonia levels, and there is a direct correlation between an abundance of E. coli and encephalitis. The second component to the GutZoomer results here gives us a general overview of inflammation and markers of digestive insufficiency. So she had elevated lysozymes and elevated S100A12 markers, which were showing yes and confirming we have inflammation. So just understanding that mutual relationship between the immune system and the microbiome, where the immune system role is to confine gut microbes, and signals from the microbiome governs development of the immune system's functionality. So the intestinal immune cells, including natural killer cells and T cells, are components of the adaptive immune system. And additionally, there are nodules within that small intestines to refer to as the Peyer's patch, which contain mature T helper cells, B cells, follicular dendritic cells, and these produce intestinal IgA. So they contribute to your immune system function. Microbiome signaling controls immune reactivity and contributes to the onset of autoimmune conditions like autoimmune encephalopathy, hence that blood-brain barrier connection. So treatment modifications after receiving the initial results, we administered high-dose IV vitamin C for several months and titrated her up to 100 grams daily for 4 days in a row, and then followed by a recovery day with Myers cocktails and glutathione IV. And this was just to further address viruses and bacteria, and then also to support her mitochondrial repair and function. We added biweekly NAD sub-Q injections. The patient was then initiated on the Levine physical therapy protocol for POTS dysautonomia. It's out of CHOP in Philadelphia. It is quite extensive, and essentially the parents and physical therapists were utilizing components of that protocol based upon the patient's abilities. She also received glutathione suppositories 3 times a day to further support detox pathways. So at our 4-month follow-up, this patient was out of bed to a wheelchair and from a wheelchair with some weight-bearing abilities. She was capable of taking several steps independently. Also, G tube feedings were discontinued, and she continued to tolerate small amounts of food by mouth, as well as medications. Her cognitive function had improved significantly. She was making eye contact. She was verbalizing. Executive functioning was returning. Significant improvements were occurring there, and the patient was conversational, alert, and engaged. Her POTS symptoms were beginning to minimize. She was still weak and had some stamina issues, but blood pressures were beginning to stabilize. So just to provide an overview of this case, you see we started in 2020 with COVID, progressive motor skill loss, IVIG was initiated, then it was stopped. I picked her up around October of 2023 with the evaluation and the diagnosis of infectious triggered autoimmune encephalopathy related to multiple infections. Then the therapy was initiated, modified, and here we are, the follow-up with the patient gaining cognitive and motor function again. We still have some work to do with this patient, but she's progressing nicely. This was the repeated tick-borne testing. And interestingly, what you'll see is it actually looks worse than the first. And this happens often where we have this patient, and now we're 6 months into it, and this was 6 months after. She's making significant gains. She's at 90% baseline at this point, still with some mild anxiety and some sluggish recall. But it's important to note with treatment, especially when you're giving biofilm treatment, that you can uncover and unleash additional infections that are there that weren't showing and being tagged by that immune system initially. So it's a really great example of an improved clinical case with what appears to be worsening labs. So it's just important to understand that. The clinical correlation, though, overall is imperative. You can't live just by what's on those labs. So we continue current treatment in order to repeat GutZoomer testing, NeuroZoomer testing, and she has some pending mycotoxin, environmental toxins awaiting. So just a couple of reflections and considerations. We're always learning, we're always growing. I know that I always am with my patients, and we're discovering new things. But just some things to consider from those new and unleashed bacterias and other microbes. That we're always finding newly discovered strains of pathogens that can have clinical impact. So you always have to continue to ask those why questions if your patients aren't getting better. A couple that are on the horizon, Babesia oticoli and Borrelia recurrentis are some that are starting to receive attention now. If you want to know more about those, Dr. Linder from iLads presented in 2021 at the conference and has a nice overview of Babesia oticoli. And these bugs, can be transmitted not just from ticks, but you can also see those from lice, fleas. There are multiple vectors that can infect an individual. Also, COVID exposure reactivation of underlying infections. I see this happen quite often and have for the past 4 years, where patients appear to be healthy otherwise, have a COVID exposure, or have a COVID vaccine, either or. I don't think there's a win with the situation at all, but can reactivate something underlying or appears to be sort of that proverbial straw that tips the immune system, and then you have this downward spiral. Other considerations, biofilms are huge. We really have to understand, biofilm coverage and the importance of that, and be prepared for what we may unleash as a result of those biofilm busting medications and herbals, and then understand how to interpret those results and clinically correlate that with the patient. So the other thought is too, with testing, currently we don't test for autoantibodies for Borrelia burgdorferi. And I'll refer you back to that postmortem study that did show that Borrelia does exist and does cross over, but we currently are not testing those antibodies to know. So there was a category with autoimmune encephalopathy that's called a seronegative autoimmune encephalopathy, where you don't have those bugs showing up as an autoantibody, or they're not affecting those certain components that we test for routinely. So that's sort of my quick overview of autoimmune encephalopathy and presenting a case. Here are some references for you, certainly to read at your leisure if you choose to do so. And thank you all for your time today, for allowing me to present.
Thank you. Thank you, Dr. Summer. I'm going to move these slides over just in case there we go. Very good. Okay, so that was wonderful. Thank you. I love that you brought everything into a case. It just makes it so much more clinically applicable once we can take that information from the research and really apply it into a real life patient. So thank you for that. If anyone has any questions for Dr. Summer and what she presented today or her case, please go ahead and put it in the chat, and we will go over those with you. So is she still, you said you have some tests that you're still waiting for. She's still in progress?
She is still in progress. And like I said, I kind of wanted a messy case to present, because this is what we see. Patients don't come with everything in a nice little box and package for you to tease through. And then also, with some of the testing, and understand that Vibrant is wonderful, but that many of these tests are out of pocket. So then you're having to gauge the most important test to correlate clinically what you're seeing and kind of validate treatment, and then tease in others as you're moving along. So that's kind of where we are. But I always stress the importance of retesting. Yes. After you're through a certain clinical treatment regimen.
Yeah, for sure. Mm-hmm. All right, so we have a couple questions. I am going to start here. We have Bethany is wondering about blood spot versus blood draw. Just kind of reiterate your thoughts about that.
The finger stick. So mm-hmm. I like it. It's incredibly accurate. I like capillary blood for testing. And I find that with children, it is quite effective. And again, with the amount of tests that that you're running on that panel, you would typically be looking at 10 to 15 tubes of blood, and on small children, sometimes that isn't feasible to do. So I do recommend a block test for the children.
Very good. Okay. We did have a question if we could show the reference pages again. So if you don't mind bringing that back to the stage, and then I'm going to go through some of the other questions too, and just kind of forward to those last couple. And just so everyone knows, you will get a copy, a PDF copy slides as well. So you don't have to feverishly write those down or take pictures of them, but we can put them back up on the stage here just in a minute.
And then so we will do that. The QR codes also will take you direct links to certain.
Oh, perfect. Maybe could you just put the QR code back up? Because there was a minute when your image was covering the QR code. So just so that everybody could scan the QR code again, let's put this back up on the stage. And if you just could kind of forward to the QR code, that would be great. And then while you are doing that, next question about alternate vectors for Lyme, not just ticks. And then the next kind of question to that, specifically asking about mosquitoes. So if you could comment on that.
So mosquitoes can transmit, not Lyme per se, but more encephalitis type viruses, West Nile virus, and things that are sort of coupled within that co-infection. So there are mosquitoes that we do, and things like malaria, and so it's kind of in the tick-borne co-infection realm versus a tick and Lyme disease specifically.
Okay, great. And one other question regarding fleas. I'm assuming any type of vector, correct?
Multiple vectors. So fleas are known for transmitting Bartonella, And I do feel that there are individuals who are exposed to fleas and or lice or things like that, other vectors, more often than ticks. So you'll see some of those infections transmitted beyond that.
Okay.
Okay, so here's one of the QR codes. Do you want me to play the other ones? They're kind of peppered throughout.
I think as long as all your references go to the QR code. Yeah. Oh, yeah. There you go. We'll put those up so make sure everybody can get to the QR codes. And then within your evaluation, for this particular patient, did you address toxins, or is that still to come?
That's the pending test. Yes. So I always address toxins. And some patients will come with their own mold testing or toxins. And if not, that is typically something that I will add to the mix.
Very good.
Okay. And it will cover heavy metals, glyphosates, BPAs, plastics, petroleum-based products.
Got it. Can you discuss pathogens being passed from mother to child in utero?
Yes, they actually are. So we know that tick-borne illnesses can be passed from mother to child. We do see it with Borrelia burgdorferi, Bartonella, and Babesia primarily. And there are studies that are showing those now. I can find that reference and give to you directly.
Okay, great. Yeah. And then let's see here. Oh, this is an interesting question. It's kind of piggybacking on your COVID exacerbation of Lyme. What about things like fillers, like dermal fillers?
Absolutely. Any underlying toxin or foreign entity in the body can trigger an immune response. So I don't necessarily use dermal fillers as the as the example, but I use other toxins in mold, just saying that they can create more of a hypersensitive state for many patients. And as a result of that, you get those bigger exacerbations and bigger flares.
Got it. Very good. Okay. Okay, last couple questions here. If and when a patient does a brain detox, how does that make matters with autoimmune encephalopathy worse or better?
I'm not sure I understand what brain detox means.
So I'm gonna go to the next.
Okay.
I'm assuming they're talking about red light helmets, infrared sauna, other light and heat therapies.
Oh, absolutely. So if you're detoxing, red light generally is penetrating the dermis and activating the mitochondria. So when the mitochondria is being reset, we're decreasing inflammation, we're expunging foreign things out of the cell to kind of help with that. Same with infrared sauna, where you're detoxing, through your pores, you're activating the autonomic nervous system to reset. So you're sort of indirectly helping that condition by resetting certain pathways.
Very good. Okay. And then will they have access to your list, your immune dysfunction framework? And then who was the original author of that?
The immune dysfunction framework is mine. And we use the MSEDS, which is Dr. Horowitz's, and that's his multi-system infectious disease questionnaire.
Okay.
Trained with him. So we use that, which he has posted freely for anyone to use. And we digitized it. So currently it's on a paper form with his office. We used it and digitized it and added additional questions to it for more neurocognitive patients. And then from there, use that to create a certain weight per question and create the immune dysfunction calculator, which is
wonderful.
Which is what we created.
Wonderful, wonderful. Yeah, and Dr. Horowitz has something called his MSIDS 16-point framework, and that's just part of his book. But the immune system, the immune dysfunction framework that you have created is different. It's kind of taken that and expanded it, correct?
Yeah, so MSIDS, we use that as a piggyback and was, as a springboard to create this additional dysfunctional framework.
Wonderful, wonderful. Mm-hmm. Well, thank you so much for your time today and all of this wonderful information. Participants, please remember you will get a email with the recording and with your PDF slides, so you can reference that. And we thank you for joining us today. Everyone have a great rest of your Tuesday.